Welcome to the online webinar on COVID-19 and technology. First, I would like to start by acknowledging the efforts of the government of Uganda through the Ministry of Health towards combating the COVID-19 pandemic. The decisions that have been made during this period by the government have been incredible, and this has created an opportunity for embracing digital technologies such as telehealth in this unfolding crisis. Speaking by names of Carol Kamasaka, the president of the Uganda Health Informatics Association, UgHIA, and currently working with the Ministry of Health as a health informatics specialist in the Division of Health Information. UgHIA is a professional association affiliated with the Ministry of Health that brings together health informaticians, health informatics researchers, and practitioners that focus on digital health care for the benefit of the health system and health consumers in Uganda. We would like to urge you to register and join the association through our website, ughia.org, for more details. Please join me to welcome our panelists who are experts in health informatics, and together they represent a wide cross-section of the healthcare and digital health community. We have Mr. Kenneth Musenge. Kenneth, can you briefly introduce yourself, where you work, and your area of expertise in health informatics?
Yeah. Hello, everyone. Thank you, Carol, for this opportunity to participate in your inaugural webinar about the use of information technology and supported technologies in terms of supporting the corona disease efforts in terms of calming it down. Like everyone has heard, my name is Kenneth Museng, and I work with the Center for Disease Control in Uganda, where I'm the Health Information Systems team lead. And well, my nature of work is about supporting the efforts of CDC through its PEPFAR-funded projects, particularly supporting HIA system design, management, data management, as well as the M&E aspect. Most of our efforts right now are towards supporting the Ministry of Health, towards having standard information systems that are purely governed and coordinated by them. We've lately put a lot of energy into establishing the e-health enterprise architecture that really supports the patient mobility and user experience through unique patient identification, integration of some of the existing systems that PEPFAR has been supporting, and ensuring that they are all interoperable and we are hosting them in the space that is approved by Ministry of Health. My experience is really IT, and I'm glad to be on this platform. Thank you.
Thank you, Kenneth. I'll ask Stephen Wanye to introduce himself briefly.
Thank you very much, Carol, and good morning, good afternoon, everyone who's on the call today. My name is Stephen Wanye. I'm currently the General Secretary, or the Secretary General actually, of the Kenya Health Informatics Association, which is the equivalent of the Uganda Health Informatics Association. And my background is in computer science and biomedical and health informatics by training. And I run a company called IntelliSoft Consulting Limited. We're based in Kenya and basically work in terms of developing software solutions using in the healthcare. So basically digital health solutions. And beyond Kenya and the region, also work globally with other initiatives, for example, the Health Data Collaboratives, Digital Health and Interoperability Working Group, amongst others. I'm really happy to be here today. Thank you.
Thank you, Stephen. Let me call Paul Mbaka to introduce himself briefly. Paul?
Thank you very much, Chair. My name is Paul Mbaka. I work at the Ministry of Health as the head of the Division of Health Information. My background is in the fields of statistics, a bit of computing, and also M&E. Thank you.
Thank you, Paul. Dr. Vincent Chiberu, can you briefly introduce yourself? Dr. Vincent, are you there?
Good morning. Good afternoon to everyone. Public Health Informatics Program. I coordinate at Computer Science, is in telemedicine and health information systems.
Dr. Vincent, are you there? Okay, I'll call our next panelist, Mr. Davis Musinguzi, to introduce himself briefly. Dr. Musinguzi.
Hi, everyone. Glad to be here. Dr. Davis Musinguzi. I'm the Managing Director of the Medical Concierge Group, a telemedicine company based out of Uganda with operations in Kenya and Nigeria. What we do is we operate 24/7 medical call centers staffed with doctors delivering consultations to patients over chat, video, and also voice calls. And if that results in a prescription, then we do last mile deliveries for medicines. And also if we need to do any confirmatory lab tests, we do last mile pickup of lab samples and run those tests and have the doctors communicate those results. All of this is integrated into electronic medical record system. We also operate telemedicine clinics, basically using connected medical devices that allow vital signs data to be uploaded into software remotely, and also enable other participants like specialists to engage in a virtual consultation room with the patients. We've also last year recently launched an online e-shop. So right now you have consumers who prefer to buy directly online through an e-commerce experience. So you can also order pharmacy items, lab items, vaccinations, and pre-book healthcare visits. And yeah, really glad to be here and share our experience with telemedicine.
Thank you very much, Dr. Davis, and thank you very much to our panelists. Now, allow me also to thank the Makerere University School of Public Health Monitoring and Evaluation Technical Support Program, METS, for collaborating with us to make this important webinar possible. We are also privileged to have the program manager of METS, Ms. Evelyn Akelo, joining us for this webinar. Evelyn, you're very welcome to our webinar.
Thank you, Carol. I'm happy to be here.
Okay. We have our webinar attendance with over 80 participants registered. So please bear with us in terms of technology and network connectivity. I know some of you are home, so the network might not be stable, but please bear with us. Before we get started, allow me highlight a few housekeeping matters. Our webinar will last 1 hour with 20 to 30 minutes of panel discussions, 15 minutes of questions and answers, and then closing remarks from the project manager, Ms. Evelyn. Please type your questions in the chat box on your screen. This session is going to be recorded and the link will be shared on our website of UgHIA. Let me introduce our moderator for the day, Mr. Jonathan Impango, a health informatics specialist who has worked within the health sector for a number of years and currently works with the METS program as a health informatician. He's also the vice president of UgHIA. Thank you everyone for joining us. Let's get our webinar started. I'll be back to take over your question and answer session after the panel discussion. Over to you, Mr. Mpango.
All right. Thank you very much, Carol. Can you hear me? Good evening. Good. All right. Good. All right. Good evening and good morning to all the listeners for our webinar. And to the panelists, I also want to welcome you. Thank you for honoring our invitation for this COVID-19 technology webinar. We want to start it off. We are all aware about COVID-19. It has been a topic here and has become a norm. But where the challenge is the word telehealth. Now to our panelists, I want to start with Davis. Davis, maybe from your own view, share with us what is this telehealth that we're talking about, so the participants can really appreciate what we're talking about here.
Great. So yeah, thank you very much for that. So telehealth simply is supposed to provide access to a medical professional or services by a patient using any kind of ICTs, information communication technologies. Now, of course, the breadth of ICT is actually quite broad, but in the most basic sense, it's somebody being able to chat to the doctor when they need one, being able to do a phone call, whether it's voice or video call, and be able to engage a medical practitioner remotely. This could be a specialist, this could be a general practitioner, this could be a counselor or a therapist, or any other kind of medical service that is necessary and tied into that. So I think there are two key elements. That one, it's providing a medical service, and the second is that it's remote. And I've seen words used interchangeably, telehealth and telemedicine. I think health just encompasses a much broader aspect of how we understand what influences health, whether it's mental, or whether it's physical, or whether it's pathological. But then also the medicinal component that is used in telemedicine then particularly relates to the fact that you're trying to arrive at a diagnosis and come up with a course of treatment thereafter.
All right, thank you very much, Davis. We are also privileged to have someone from Kenya to give us their perceptions of how they understand this terminology, telehealth. Maybe to break it further for someone to understand, Stephen Wanye, what is your view of this term that you're referring to, or that we're talking about right now here, telehealth in this era of COVID-19?
Thank you very much, Mr. Mpango. And I mean, I think I joined Dr. Musinguzi basically in terms of definition, but only I think just to extend it a little bit to mention that from the Kenya Health Informatics Association perspective, we see that definition within the same lens, basically appreciating that telehealth really involves the use of telecommunications and virtual technology to deliver healthcare outside the traditional healthcare facilities or healthcare system as it's known. And basically, at its most basic element, telehealth really just requires access to telecommunications, which basically uses a wide range of ICTs, as Dr. Musinguzi has mentioned. And a couple of examples that have been alluded to include virtual home healthcare, where, for example, a patient who's chronically ill or an elderly patient, for instance, or maybe a nurse aide, clinician aide would receive guidance from someone who's more qualified in terms of certain procedures while remaining at home. So it's really similar in a lot of ways to the previous definition.
All right, thank you very much, Steve, for that. So we want to continue breaking this further. We want to get the sense of how this telehealth, Dr. Msunguzi talked about telemedicine, how we are able to utilize it in this era whereby we are being told not to get closer to one another, to maintain social distance. But again, healthcare becomes crucial and key. Now, we want to break it down. How are we using telehealth in this era of COVID-19? I want to start with the Minister of Health position. Paul, tell us, share with us your experience. How are we using this telehealth in combating COVID-19 in Uganda?
Thank you very much, Jonathan. As you know, allow me to theorize a little. Those that theorize accepting technology usually say that technology acceptance is not a function of whether it is useful or easy to use, but whether it is perceived to be easy to use or perceived to be useful. COVID-19 has presented us with a good opportunity where we have a significant number of colleagues in our leadership that see technology as a solution for some of the problems that we have, and have actually demanded far more than we have been able to deliver. COVID being an extremely aggressive disease is quite easy to transmit, and providing remote care becomes very significant as you progress within the pandemic. You have situations where you need to protect your healthcare workers, and so you have to find creative ways of limiting contact. And this presents very good opportunity for telehealth So, but technology has been used far beyond that. As you know, at the core, okay, as you may know, at the core of any epidemic control is things like, is basically surveillance. You have to be able to classify correctly and be able to find those who have been in contact with whoever's been classified as being positive. So these are the interventions that are core of breaking transmission chains in an epidemic. And technology has come in very useful in this case, using things like Bluetooth to determine whether people have been to close proximity with each other, issues around using GPS to find out where, but particularly for telemedicine. In Uganda, we have not deployed telemedicine yet, but we envision a time as the numbers become significant, we will not be able to manage them within our healthcare setting. And the only way to optimize the little resources that we have will be through a remote care modality. And nothing suits this more than telemedicine. So for us, we are actually putting in place things that we did not have before, things like procedures and guidelines that will allow us. We are reaching out to colleagues like Dr. Davis Musinguzi, who have been in this field. They have shared some insight, which we are building into our plans. And when that time comes, which we are sure is not very far in the future, we will be prepared to deploy telemedicine to support with remote consulting, providing procedures and guidelines to those that require it, and providing care without necessarily being within the physical proximity of those that need this kind of care. Thank you very much.
Thank you very much, Paul. And thank you for mentioning about Dr. Msinguzi, who we also have as part of our panelists. And Dr. Davis, can you please share with us, how does this thing really, how are you using telemedicine? Tell us, break it a little bit for us to understand how this thing really works. Before we hear from Kenneth, Dr. Davis, please share your experience.
Okay. I think many of us at any one point in our lives have had to go to a hospital or go to a clinic for any kind of condition that may have brought us discomfort. Now, ideally, when you go into a healthcare facility, you're first going to be welcomed by the reception desk, where you'll have to register certain information or get asked certain basic details, or you'll find a waiting room where you wait for your turn amidst other patients. And the first point of contact within a physical facility, of course, is normally triage, where they'll take some basic questions, they'll take your weight, your blood pressure, etc. However, what we have found is that about 60 to 70% of the conditions that take people into a physical facility can actually be done also remotely. So the primary purpose of telemedicine is to identify if a first point of contact through a virtual communication can be sufficient to identify what your health challenge is. Now, the way that we have set it up is that we try to make sure that it's all inclusive, regardless of how comfortable you are with technology. So if you are more comfortable just making a phone call, for instance, my grandma only knows how to make a phone call, for instance, we still want to make sure that she's able to reach a doctor, and we're able to deliver that through dedicated toll-free lines that can connect them to a doctor directly. You have different categories of people that prefer to use chat. So we've also made it possible on several chat platforms for you to be able to engage a doctor through chat as and when you have any conditions. And then, of course, there is video for those that can have smart devices and can afford the bandwidth that comes along with it. So what we basically try to do is do some triage to understand how urgent or how complex is are your health symptoms. If we identify that you're going through what should be an emergency, then telemedicine is not something that you should be opting for, unless, of course, it's for the purpose of providing first aid. The next thing that happens is really about taking history. So really good medical practice should follow the trend where several questions are asked that enable the doctor to come up with certain possibilities of diagnosis that we'll either need to confirm or rule out. Sometimes you have enough information from history to make that decision on a first line of treatment. And some other times you need to do some confirmatory lab tests or imaging to confirm that diagnosis. So in the scenario that we have enough information to write you a prescription, then we deliver that prescription out of our pharmacy and have that get to you wherever you are, at home, at school, at work, so you can get initiated on your treatment and we can follow you up a few days later. If at all we identify that we need more confirmatory information for our diagnosis, what happens is that our lab technicians will come to wherever you are, draw your sample. It could be stool, urine, blood, bring that back into our lab safely. We run the tests, get all those test results into the electronic medical record system, and the doctor gets a notification that your results are ready. They call you back, explain your results to you, and determine the next course of treatment, whether it's pharmaceutical or whether it's a referral to a specialist, or whether we notice that there's something that's particularly off that needs you to go into a hospital. So I think the key aspect about telemedicine is really trying to identify and discern whether this is something that you can manage remotely, whether this is something that needs an outright prescription to resolve, whether it's going to need a lab service and how you can coordinate care thereafter, or if even at the end of all of that, this person is going to need a physical examination for you to be able to determine the next best course of action. So that's ideally how it does work for us at the Medical Concierge Group.
All right, thank you, Dr. Davis, for sharing your experience. Now, I want to turn to Kenneth from CDC. We are cognizant that CDC has been supporting health information systems, especially to the Ministry of Health. How are you using how are you supporting this initiative of using telehealth as PEPFAR or as CDC? Can you share with us your experience on how you are going about this, Kenneth?
Thank you, Jonathan. So again, like Paul and all the other participants have mentioned, aspects about deployment of telehealth are really in infancy stages, and probably COVID has given us an opportunity to probably fast track and see how we embrace this kind of technology, especially we're living in times where we are living in times where, you know, we have that internet connectivity is rising up to probably 40% of the population. Most people have mobile devices, but getting back in terms of CDC, it will get us to aspects that I will put probably in 3 aspects. One, I'll try to look at how do we want to deploy this technology to particularly support aspects of prevention, aspects of detection, and then in terms of responding. So you find that right now, most of the aspects have been, I'll start in terms of prevention, which has not purely been a CDC initiative, but, you know, trying to use technology as part of telehealth to support, you know, health communication. This has involved a couple of partners. All the telecalls have been involved, you know, where they are sending out information about, you know, social distancing, wash your hands, stay safe, stay at home, and everything. All that is all about, you know, prevention aspects, because we don't want it to go to another level in terms of being exposed and then you become a case. But the other area of support has been that, okay, even as the prevention is going on, and for instance, if you've been detected and then you've been deployed into, and if you've become a case in terms of detection, what are some of the areas that CDC has been supporting together with other partners? It's been in terms of, you know, case management, in terms of like how clients are followed up, how certain key information is gotten from them. It's kind of managed and processed and reported back for decision making. So there's been a lot of initiatives around supporting, trying to use leveraging some of the existing initiatives, especially around Central Public Health Lab, you know, TPHL that we all know, in terms of following up samples and tracking. For instance, if a driver came from Busia at the border and, you know, they were able to get the specimen, the sample from them, but they're allowed to move on, you know, trying to deploy technology around EIDSR, so that if they give you a sticker with a barcode, you're allowed to move on. But every time you look at certain, and, you know, then your sample is brought to UVRI for testing. So even as you're moving, we are able to use technology to make sure that should the results come back when you're positive, for that matter, then you know, they're able to give you a phone call and follow you up and tell you the next things to do. Or even when they are negative, they're able to communicate to you and know that you're negative. And then what happens that in terms of communicating to teams of who comes to support you and what are the next steps that happen after that. So most of, and if your sample, like to get back the sample, if your sample is drawn, let's say from Busia board or Malaba board, at any one time, you know, they are trying to use technology built around the sample tracking app to understand where the sample has reached, who has it in terms of chain of custody, and until the resulting happens. So that has been one critical area that we've been trying to use it. So in terms of the cases that have been going, like colleagues have mentioned, things are still in the infancy stages where I would have expected probably technology to be used in terms of, you know, remote monitoring. I don't think we are doing that, but monitoring aspects that go with the data that is collected around the cases and the non-cases, and then the movement of results and samples. So there's been teams working around in terms of integration of some of these disparate systems. You find that there are a couple of systems that are managing the lab aspect of it, the sample aspect of sample movement aspect of it, but also people doing maybe issues about trying to follow up the chain of your movement to, you know, to do the case tracking and everything. So CDC's support comes in terms of, you know, trying to bring the efforts to synergize with the different players to make sure that, you know, there's a bit of integration of these systems to make sure that there's a holistic picture about most of these cases in terms of efforts that are being done by the other people, whether in the lab, whether in terms of follow-up, whether in terms of, you know, continuous education and other things. So largely that's where largely it's been mostly. So it's been mostly about the using some of the existing contributions done by the other telecoms in terms of prevention, but aspects around the management and governance of the data and the technology involved in terms of making sure that this data is available. Thank you.
All right, thank you very much, Kane. Steve, do you also want to share with us your experience on how you're using telehealth in your sector?
Sorry, Jonathan. Yes, absolutely. No, thank you very much. So, I mean, I think I'm speaking, again, I'm speaking on behalf of the Uganda Health Informatics Association, but I can also share experiences about what's going on in Kenya. I'm aware of what the Ministry of Health in Kenya is doing, and I'll describe that really quickly, and also speak about what the private health sector in Kenya as well is doing. So from the ministry perspective, they've set up an elaborate surveillance system, pretty much, which has the following components. So there's a component on case identification and notification, where basically the COVID-19 suspects, a case can be identified through any of the following major methods. So whether it's a self-reporting travel history from a country with COVID-19 history, contacts with COVID positive patients, diagnostic in a hospital, and community-based surveillance. And for this, the ministry has, as part of that component, a traveler surveillance system and watchers who monitor this. Then there is another component or part of the process for case investigation and isolation, where a case is currently being registered in a COVID tracking mobile application, and Kenya EMR, which is one of the most dominant EMR systems powered by OpenMRS. And this is registered by the surveillance teams. Notifications are made and the lab request is made as well, which is done by the system. And the system has decision support alerts for every milestone and discontinuation with an outcome that is arrived at. And then there's contact management, where again, the Ministry of Health in Kenya has set up a process where if a case turns positive, all his steps are followed back to onset of suspicion or contact with the virus. This involves people met, areas visited, and activities carried out to manage transmission rates. And for this, the ministry is using a combination of Kenya EMR, COVID tracking mobile application, and another mobile health application called UgHIA. It's an Android application. I forget what UgHIA stands for, but it's being used in the Emergency Operations Center. It's really running on Android-powered phones to aid that activity. Then, of course, there's a component of strategic information, where the COVID-19 surveillance team relies heavily on accurate, timely, and informative data to help them make decisions on the go. And for this, they have set up again systems that are being used that include Kenya EMR, and they also have analytics and visualization dashboard that is powered by UgHIA, which I think most of us are familiar with, built by a company called ESRI. And then there's also the quarantine management as well, where when cases are identified as positive or in contact with a suspected positive patient, they're registered and enrolled, quarantined from the rest of the population and followed up or transferred to another quarantine center in case of other factors until an outcome is recorded. And in this stage, Kenya EMR and EA's, this Android-based application are being used to manage this activity. So that's sort of like the enterprise system that the ministry has set up. It has a lot of, I would say, telehealth, digital health interventions within it. Yeah, but it's a complex system, pretty much combining or comprising of disparate systems. And underneath that, the ministry has an elaborate enterprise architecture with an interoperability framework based on standards that enables FHIR-based APIs to exchange the data. So it's really leveraging on a lot of historical investments. Now that's the public health sector. On the private health sector, the Uganda Health Informatics Association, and I was hoping that my chairman, Dr. Tom Muluch, is on the call. I hope he is. We've partnered with the Kenya Healthcare Federation and also the University of Nairobi and other partners to basically work together with all the private health sectors. And one of the use cases we're using is we're really being targeted and focusing on patients who are at a higher risk of getting infected with COVID with severe outcomes. And obviously we know from science, these tend to be patients with existing chronic conditions like cardiovascular diseases, diabetes, elderly patients and all. And so we are focusing on that as our use case to enable us to get maximum impact. And for that reason, currently we're in a stage where we are reviewing a lot of the available telehealth, digital health solutions to figure out the best combination to create the ecosystem. And all that is based on an interoperability framework called OpenHIE. Thanks, Jonathan.
All right, thank you very much, Steve, for sharing with us your experience. Now, the other question I want to ask the panelists, what does it take to implement telehealth, especially in low-resource countries like Uganda? I want to start with Paul. Is it about technology to have this done? Share with us your experience on that.
Thank you very much. Jonathan. Of course, in situations like this, there is nothing more important than being able to optimize the deployment of your resources. Now more than any time, you need mechanisms of deployment that will allow you to save resources. And telemedicine, while we have mentioned all these cool benefits about it, the one thing that it does is it is optimal in that sense. It saves resources for those that are seeking care, but it also prevents those that provide care from deploying significant amount of resources for, say, setting up infrastructure and the like. I know sometimes people say, how would you deploy technology in a low resource setting? Actually, some of this technology like telehealth are more suited for low resource setting than in other settings. So for me, I see this as an opportunity, actually for us in Uganda particularly. Some of the things that we have been struggling with, it seems a little easier to introduce them now because the benefits are immediately obvious, but in terms of a cost-benefit analysis, or even just a comparative analysis with the alternatives, it always seems a cheaper option when you deploy technology. Thank you.
Right. Thank you very much, Paul. Dr. Davis, I want to get back to you. You have implemented telehealth. How have you been able to manage change management? Do you want to share with us your experience in that angle?
Great. Yeah. So I think one thing that is important to realize is that there are particularly different modalities that you could offer telemedicine. In one way, it could be a direct provider to patient telemedicine interaction, but it could also be a provider to provider telemedicine interaction, where you have a primary care doctor interacting with a specialist, or a primary care doctor interacting with a community health worker that is delivering services in the community. And depending on what modality of telemedicine or telehealth you want to deploy, you know, it helps you think about what aspects of change management are required. Because what you want to do ideally is to replicate as closely as possible what currently exists within their workflow that they are accustomed to, and making sure that you only take the advantages of introducing technology in there to create different efficiencies. So there's always some level of feasibility that has to happen to determine where you may find some gaps in how care is traditionally provided, and where you think you're going to need to do some extra training. So internally, what we have had to do is even change, for instance, things like our hiring process around the medical doctors that we get into telemedicine services, and start attuning them for what we call website care versus, you know, bedside care, which is what they were accustomed to. So there's a lot more training that is required around what you would call customer care, so that the doctors are more empathetic, they are more polite, they're active listeners. They try to be as exhaustive as possible with taking history, because there's less reliance on you being able to see the patient. And it's tweaks here and there in how you do your quality assurance and also monitoring, to make sure that you identify those areas where you need to improve how the resources that you have, be it doctors or the technology, really does fit into the modality of the telemedicine that you do want to provide. The other kind of change you also need to consider is based on the technology that you're going to provide. How much of a mental leap is it actually going to be for the participants in your telemedicine process to adapt to technology? So is it, you know, whether it's around video, whether it's around software, or whether it's around video communication tools that are integrated with electronic medical records, or whether it's around connected medical devices that are transmitting health data via Bluetooth or remotely over the internet. So there are all these different elements that you have to consider in the design of your telemedicine solution. Its feasibility that will help you really inform where you have deviations from traditional care. And those are the opportunities that you have to pay attention to regarding any change management interventions that need to be undertaken.
Thank you very much, Dr. Davis. Paul, I get back to you. As a country, Uganda, how ready are our health professionals to embrace technology? What is the plan? Can you share with us the plan for Ministry of Health, Paul? Paul?
Sorry, Jonathan. Even I am getting used to technology.
Yes, it's more about change management. How ready are we to prepare our health workers to be able to embrace this technology? Dr. Davis has just been sharing their approach, their methodology they have used. But from the perspective of Ministry of Health, where are we? What is the plan to ensure that people embrace it and use it?
Thank you very much, Jonathan.
Yes.
The point I made at the beginning related to theories around technology acceptance. There was about perceived, I mentioned perceived usefulness and perceived ease of use. While ease of use might be a challenge at the moment, we have scored very well on perceived usefulness in our current context. And I think the opportunity is to leverage this. Where we are deploying technology now, there is uptake, because it is not an issue of whether you enjoy to use the tool, but this is the decision that has been made, and you have to go by it. This is not to say it is important to have buy-in and to have people appreciate that a tool is easy to use. And the issue around change management is a big deal. Of course, given our current context, in an epidemic, this is a rapid onset problem. You do not necessarily have time to do change management the way you would usually do it. But for our broader interventions, we are in the process of developing a change management strategy. If it wasn't for COVID-19, perhaps we would have already started implementing strategy by now. But we are trying to implement that. In the context of COVID-19, it is not something that is easy to do. The only thing that you need to do is to demonstrate that an application is helping to solve a problem, and it's a bit easy to use. Of course, we've experienced some challenges with some of the solutions that we've tried to deploy, but one thing that has always proved to be useful is availability of a technical team to quickly respond to questions that people ask. I've realized that in our context here, we say everything that we want, but it looks like health workers are ready to embrace technologies. The problems that they typically experience is that there is some form of hesitancy to help by those that provide these solutions. We sit in some rooms as techies and think the way we think in our own perception, but many times people can look for a W on a keyboard and find a hard time tracing it. And when they express that to us, we think, oh, come on, why wouldn't you see a W? It's right there next to the Q. But someone could be using a ZATI keyboard and the Q is not next to the W. So it is important many times for there to be a willing team to provide the kind of support, and most especially in contexts like this where you don't have time to go through an elaborate change management process. Thank you.
All right, thank you very much, Paul. Now, the other question I want to ask to the panelists, and I think I'll start with Ken. What are the known telehealth challenges, and how ready are we to address them? Kenneth.
Thank you so much, Jonathan and everyone. The challenges, many have already been mentioned by some of the contributors that have been contributing. Like one of them you've been discussing is the issue about change, resistance to change. You know, when it comes to newer technologies like these ones we are talking about, like using technology as a conduit of delivering health, I can assure you that there are challenges about embracing this technology by both providers and the users, and several studies have also, you know, indicated this. And then when you're talking about it, when you're talking about telehealth, you know, there are three aspects involved. You're talking about the people who actually give the service. You're talking about the people, the service providers, let's say the medical team. You're talking about IT experts, and then you're talking about the other technology. So, but also the other people on the other side who receive the service, okay? They also need to be served in a way. So if there's some bit of issue, if there are issues about the ICT literacy, then there are really challenges. And this has been a growing concern, especially when in some of these low developing countries. So there's this bit of hesitance about new technologies. So IT literacy issues really affect. Some of the other aspects again is the lack of regulation bodies. So Davis has mentioned about how they are trying to do it, but I bet if you asked Paul, like somebody, sorry, who is representing the Minister of Health, and you say, are there adequate regulatory bodies and guidelines of how this telehealth should be done? Or it's about saying we are building the vehicles, we ride it. So it's also very important that, in terms of standardization of the practice, that issues relating to policies and regulation are also addressed. So that can be an impediment to this. But at the same time, you need champions. I mean, you need people you need clinical teams that are, that really like using the technology, that want to do things from the different way of sitting on the desk with people and discussing with them. But you need somebody who will say, I'm comfortable being in the clinical room with these gadgets, and I'm talking to somebody who is thousands of miles away, and I'm trying to solve it. You need such champions. So if you don't have such champions for IT at the same time, like Paul was telling you, that they are lucky that right now with the challenges they're having about the simple technology they've deployed, they have people on the ground to kind of, be able to respond quickly. So if you don't build those kind of champions around, then it gets impeded. But we don't also have to forget that there are issues about the technology itself. We are talking about technology that is probably on mobile devices, technology that is about communication platforms, probably they are going to be video or whatever. So technology itself also becomes a barrier to telemedicine or this telehealth, especially, when you look at the costs of acquiring it, the costs involved in acquiring it are our governments, our partners, have they really planned for it to say, we are ready to acquire this technology and maintain it? So if such aspects are not really catered for, then it gets a challenge. But there are also issues about other infrastructure. So you're talking about doing things remotely. For you to be able to do this, you're going to need a proper and adequate ICT infrastructure. So, you're going to need the internet, you're going to need power, you're going to need, you're going to need other accessories that go with the platforms that are provided. But, have we planned for this? Are we ready for this? Are we ready to have them and maintain them? And, considering that most of the people who seek our services are in remote areas, like Paul said, the people who should even benefit most from this kind of innovations of telehealth are actually people who are in remote places. But in these remote places, do we have power? Do we have internet? Do we have, the bandwidth to actually support these things? And then the initial startup costs, of course. I'm sure Davis has made it look like simple, but if you ask him that, what did it take you to set up these kind of platforms, he'll probably give you his own story of what it has said, because some of the technologies we are talking about being able to deliver things through voice, through text, through pictures, through audios and videos. For instance, if you're going to scan, maybe somebody is affected somewhere in Budud and you do a scan, and then you send it over to an expert in Mulago to expand it, to study it and then take back the results. You need good internet. But, are we looking at the initial cost that it takes to set up, a medium that supports that kind of technology? So it can also be a barrier, but I mean, we're also talking about their legal barriers. So we are saying, as you get into this practice, you're going to find that it's not the traditional delivery, but you're talking about doing so many things remotely that will involve exchanging maybe private issues, exchanging data that has PII, or things that would require much confidence, but now you're putting them into media probably that are not very secure. So what if they're intercepted along the way by other parties? What happens? What if somebody just, you have a tennis? I'll give an example here of our local tabloid, Ready Paper. What if it just wakes up one morning and say, Kenneth has syphilis, and it's a big heading just because they were able to tap into a line somewhere and whatever? Are we ready for some of the legal issues that will come out of that? And then, the issues about licensing. So if we are going to allow these people get into telehealth, let's not look at it in the dimension of only Minister of Health, which always comes up with general kind of guidelines because it has the biggest wavelength in terms of practitioners. But when it comes to people like Davis, who is licensing them? Who is licensing them to make sure that whatever they are doing with all their sophisticated technology, it is safe, it is secure, it is speedy, and what happens that? So that becomes an impediment. And then when you're using this kind of technology, how do you go about issues of consent? Okay, because we need to put a clear understanding of some of the implications, rules, and regulations that would come about especially if people got informed about their rights and other things. So if you did something and which probably didn't seek the kind of whatever, what happens? So the list is long, but most importantly, I think what is very critical is making sure that you have the right policies in place, you have a mindset of people who are actually ready to embrace the technology, and then you also need to create very strong partnerships, because when you look through the channels we've talked about, we are saying if internet is an impediment to this kind of arrangement, how do you partner with other people out there, like maybe telecos? We've been talking about, zero-rated platforms or subsidized, So it's very important. It takes just Minister of Health, but it takes a couple of other things. Thank you.
Thank you very much, Kenneth, for that in-depth analysis about that. I want to ask Steve to mention something. In your area in Kenya, what are the known challenges that you have encountered with when you are administering telehealth? Maybe quickly, can you share with us your experience in that?
Thanks a lot, Jonathan. I mean, I guess I would say in Kenya it's very similar to what Kenneth has mentioned in a lot of ways. And I think I would say maybe one of the ones that I've not had discussed a lot on this webinar is the need for making a case for investment in telehealth requires better evidence. And I don't think we've done a good job in terms of marshalling existing evidence to not just show what that telehealth actually works, but to also show where, in what context does it work organizationally. Do we have evidence from both from large scale, very well controlled studies, but also to mainstream implementations, like the work that Dr. Musinguzi is doing, for example, that requires us to carefully synthesize the data and taking into account not just the clinical dimension, but also other dimensions relating to successful implementation within routine care. Change management, I think, has been discussed a lot, human resources, and other determinants and components of the healthcare system. The other component, Jonathan, I think I would mention is, and Kenneth has also spoken about this quite elaborately, I think is, with telehealth is not business as usual. So for example, the business case for telehealth means that even the financing mechanisms must be critically assessed for the abilities to either incentivize or disincentivize telehealth service delivery, because it's very different for different players. Medical legal issues then come into play. What can you charge? What can't you charge? Are our health payers ready for that? Are the premiums we're paying? If I get a telehealth consultation, do I pay out of pocket? Do I get that paid for? The different regimes must be compared in terms of identifying best practices. Then, of course, I think we spoke at length about change management. The role of partnership is very, very critical. Technology on its own will not deliver change. Change management must fully engage all involved participants and all stakeholders. I mean, on this call, we have so many people, and the global digital health community works as a big family. And I think the fact that this webinar is being hosted by Uganda Health Informatics Association in conjunction with Ministry of Health, CDC, and all the other stakeholders in Uganda and beyond Uganda is a clear demonstration that strong partnerships are required for this to work. I think we keep speaking about PPPs. When people talk about private-public partnerships, my definition of PPP is we're here as a digital health community, and I look at that from a perspective of what is the potential for digital health, what is the power of digital health, and what is the promise. For me, those are the 3 Ps. Thanks, Jonathan.
Thank you very much. And you've just talked about having a community. And my next question maybe I'd want to hear from Dr. Vincent Chiveru. How can we build this community of health professionals that are telehealth savvy? Dr. Chiveru, you want to say something about that?
Thank you so much, Jonathan. I was happy to keep a passive panelist, but let me contribute on this. Well, I appreciate all the submission from my colleagues, but I'll specifically quickly talk about how we can build a community with telehealth savvy. Yeah, most importantly is that we need to establish policies and guidelines that will guide use of telehealth. That is critically important. I remember Paul talked about it, that something being worked on at the Ministry of Health, because without clear policies and guidelines, it will be hard to kind of integrate telehealth into our healthcare delivery. And another thing I would think we need to provide incentives and motivations to our health workers to be able to embrace telehealth, because in most studies have indicated that telehealth is more of like an additional work in the within the facility for health workers, in addition to the rest of the work they have to do. So there has to be some bit of incentive for them to use telehealth in delivery of healthcare. And maybe the other thing I could look at is to probably introduce e-health training right from the formal training for the health workers. That
Okay, I think we have lost.
would be good. To able to embrace this right from that would be something good. Thank you so much, Jonathan. Yeah.
All right, thank you very much, Dr. Chiveru, for that view. I want to go back and lastly have some few questions. I know time is not on our side, but I wanted us to briefly discuss about the role of telehealth in communities. We have at least talked about telehealth in facilities. Now let's take it a little bit further, because right now, for example, in HIV, the model app right now is distribution of drugs in the communities. How is telehealth going to come in to help? I want to hear from Kenneth, and then Dr. Davis, and then Paul. Let me start with Kenneth.
Jonathan, in terms of how we take this down, again, it will bring me back to what Chiberu was discussing. I mean, for us to ensure that this telehealth is really built within our community, regardless of who is going to use it, right from the community, right from the higher levels, right to the lower level units in the communities, I think there's one key aspect that I didn't hear him mention, which is about having a skilled workforce. It's quite important that as we move into telehealth, regardless of how simple or how complex the technology is going to be deployed, it's very important to build a skilled workforce. But before we even build this skilled workforce, again, it gets back to people like Paul and Baka and others who are within the Ministry of Health to ensure that, you know, people within Ministry of Health who want the existing health system to use resources in the community, because when we talk about the community, like in the Ugandan context, you know, the people who have in our communities who are really supporting the health system structure, health delivery. You know, we have lay healthcare workers, we have village health teams, and we all know their level of understanding about some of these things, despite the fact that they can play a greater role. So it gets back to having, you know, a knowledgeable and decisive leadership, which actually appreciates that, you know, that it's important to have a vision of how we are going to exploit these kind of technologies at all levels within the health structures. So if a vision is put in place, and, you know, in terms of and very good leadership, and then proper strategy for building skills, you know, at all levels of the healthcare system delivery, right from, you know, let's say national, regional, referral hospitals up the lowest level unit, which is within the community, it gets a little bit easier, because it means that even they are recruiting a VHT, for instance, they will be very mindful about the kind of person they are kind of deploying, because they will say, oh, within our strategy, we actually have to use telehealth, or we will be using some of technology as a conduit to deliver health. So you not just get any other person to be your only person in the community. So it's very important that when they are recruiting that, and they will have such skill sets within the kind of people they are looking at. Nonetheless, I think right now, in terms of what can happen in the community, there's a lot that can happen, whether in HIV or community, that can be done by telehealth. You know, one, in terms of signaling, let me start with within the context of COVID. If you have people out there who are in the community and you don't want to overwhelm your system in terms of who is quarantined in institutions that are set up by government, but if you have to maybe monitor and quarantine people maybe in their homes or in other safer places in lower level units, but, you know, exploit technology to make sure that whether somebody is in, you know, a remote place or somebody is in grade B Entebbe, grade A Entebbe, they're still getting the same benefits and they're not worried. But all you're doing is exploit technology, maybe in terms of monitoring vitals, you know, and then making sure they are related to people elsewhere who understand and interpret them, and then work with somebody on the ground to manage the situation. But again, getting back to the other issue of signaling, that you have people who are savvy, a bit, who have some skill sets, use a phone or whatever, and get the rumors or pick the signals that somebody has a temperature, is coughing, and they type in an SMS and probably escalate it to another level. I think that will also be very important. But also now, in terms of HIV, if I get in the context of HIV, trying to use portals or coming up with apps and putting them on mobile devices and having people, you know, probably do some bit of documentation as they deliver services in the community. For instance, if they're delivering ARVs into the community, into certain groups, as a decentralized strategy of, you know, of taking these services. You would not want to have such people go with the papers again and writing a lot of information. Maybe sometimes they can't even write, but if you've created some kind of capacity around using simple portals where they can get it and document a few vitals, basic things that have given this person X ARVs, this number of pills for this number of days. And, you know, I found when he's okay, didn't have complaints, and then push them over to another level where people can look at critically and then be able to make a comment is very important. So to me, being able to deploy, I just want to sum it up, being able to take technology, to use technology as a conduit within the community health, we're using mostly the resources that we always use in the Ugandan context within our communities, like I said, lay healthcare providers, village health members, and volunteers and everything. It's very important that something is done about skilling them. A clear strategy has to be around as the way of skilling them and how they are really selected. And that alone is guided right from what I said at the beginning. It starts with a clear vision, which is guided by very good leadership that is really, you know, that is really focused on aspects of embracing telehealth. Thank you.
Thank you very much, Kenneth. Paul. Yes, Paul, can you give us your view on how we can roll out telehealth in the communities, especially MOH division?
Thank you very much. I think it is important to highlight the context in which community health is provided. We typically use community health workers that may most of the times not have the same rigor of training as those that would find in a typical clinical setting. Those more than anyone require mechanism for consultation. They need to be able to quickly seek guidance from those that have better expertise from time to time. Because if you look at a disease that is significantly prevalent in Uganda, like malaria, it can present with just a headache, with just a joint ache, with just a stomach problem, with a fever, or any combination of those, including either having all of them or some of them. So for someone, a VHT who presents themselves at a particular household and they observe something, many times they would need a quick way to provide, to seek consultation. And sometimes they do this, albeit in a non-structured way. They call their supervisors, they call facilities they're attached to for some guidance. But I think it would be a better thing to do if this was a structured process, so that there is a deliberate effort by the Ministry of Health to put structures in place to allow VHTs or typically community health workers to have mechanisms for remote consulting with experts who are removed from the places where they are. So I think the opportunity to roll this out is actually right. It's just for us to ride on the opportunity that presents itself. Thank you.
Thank you very much, Paul. And Dr. Davis?
Wow, well, so much has definitely been said around that. And indeed, I feel that from our experience, telehealth is something that should be integrated across the entire referral system, straight from a member of a community who identifies that they have certain health symptoms, and they use telehealth as a means of early detection of any possible disease conditions and get the treatment that they need in a timely way to prevent that from escalating and becoming a greater burden on the healthcare system or even financially on the individual that is involved. And then even in a situation that gets referred to a community health worker, providing the community health worker, again, resources that enable them to use telehealth to interact with their medical professional at their nearest healthcare facility in case the patient is not able to get to that health facility in time, so that we have savings on time. We can be able to maximize that golden window of opportunity to deliver care within the communities. And even when it's within the context of the healthcare facility, we know very much that a lot of specialists are centralized within the capital cities, the big towns, and you have a lot of lower level facilities that do not have the luxury of having quick access to a specialist. So enabling specialists participate in remote consultations at these lower level facilities, that a lot of those patients don't have to come and crowd regional referral hospitals or the national specialized hospitals. And if we can really do that, we can optimize efficiency through all those different levels by managing conditions at the point that they first present, and only escalate those that we feel require a physical engagement within those higher level facilities. And I think that's how we'll achieve better health outcomes. That's how we'll have more cost effectiveness, cost benefit around that. So we've been fortunate to have delivered some 5-year-long USAID programs within certain communities, and we are very positive that the outcomes speak for themselves, whether it's around HIV care, maternity care, TB care. There are results that show that telemedicine is delivering value across all these different public health verticals, and there just needs to be more organization across stakeholders and an investment plan to deliver these solutions to the people that need them the most in the community.
Thank you very much, Dr. Davis. So let's wind up this session with some questions from the audience. And I want to ask Carol to take us through that. Thank you.
Thank you very much, Jonathan. And a round of applause to our panelists for these exhaustive responses to the questions that our moderator was asking. We have a number of questions, but we are going to answer only a few. The rest of the questions will be posted on our website and answers given there. I've shared the link to our website in the chat, but I can share it again. I'm going to ask Paul first a number of questions. Paul, we have Brenda, who's suggesting that can the government develop mobile applications, or has the government considered developing mobile applications for infection detection and alerts for the contacts of the infected people, putting in consideration the stigma surrounding the COVID-19. Paul, the other question for you is, when are we having regulations and laws to guide telehealth in Uganda? Another question is, what will be the influence of the proposed health insurance policy for Ugandans as far as telehealth is concerned? Paul, those are your questions. You can answer them.
Thank you very much. Let's start with the first question. Government of Uganda developing applications for infection prevention and control, and some of them used for tracing of contacts and so on. Yes and no. Typically, of course, we do, as government of Uganda, our modality is not to have a significant amount of expertise in-house, but through partners, through our partners, and also sometimes engaging the private sector, we've been able to develop some of the systems that we need. Yes, we have applications both deployed and some of them that are coming up. We have a system that is commonly used across the world that is based on Bluetooth technology that can help for those that have subscribed into it to tell you whether you have been in close proximity of anyone who is infected, and then advise you on seeking help. We have not deployed this solution yet, but we are in the process of having it evaluated. And there are many solutions that are in this direction, and we can find mechanisms of sharing them widely. In terms of sharing this initiative widely for information with colleagues who have participated in this webinar. In terms of regulation, Madam Chair there is at the forefront of developing our telehealth guidelines. I think it's in very advanced stages. In the next week or so, we shall be able to present it to our Director General for clearance. We are lucky, we're in this COVID-19 dispensation where many things are fast-tracked. So if we finalize this, its approval will not be delayed. So the question, the next question is about how does health insurance, the proposed health insurance, how would it affect telemedicine? Actually, telemedicine or telehealth is not different from any other mechanisms of health. And the challenges typically with an insurance is how do you bill effectively? But with telemedicine, you actually have parameters that you would typically be tracking, better controlled. actually easier to do billing for telemedicine. And therefore, I dare say it is more suited for an insurance mechanism than the traditional health things, because the validation and the auditing is a little more straightforward for telemedicine than it is for services that are received in some of the other clinical settings. Thank you.
Thank you very much, Paul. I'm going to ask the next set of questions. I'm going to throw them to Dr. Davis. How does the shared health record fit into the telemedicine platform? Davis, your next question is, what procedures do you use to deliver the drugs safely? And lastly for you, Dr. Davis, in countries where telemedicine is happening, how do you go around the legal aspects of personal private information? Is it not costly to venture into it and work effectively? Over to you, Davis.
All right, so regarding the question on shared records, it is definitely important that you keep an electronic medical record of all your teleconsultations. So if it's voice or video, you want to make sure those are pre-recorded and securely stored. If it's chat interactions, you want to make sure that those are made available, uploaded into your electronic medical record. If any images are shared, you also want to make sure you have that added in there. So for us, an electronic medical record is no longer just a text-based record. It is actually a multimedia patient record. And there's some work underway on trying to figure out how do we make this integrated into, let's say if you have a chain of clinics, so that it's accessible remotely, regardless of which clinic you go into, or if you go into a public healthcare facility, or if your insurer needs to look at that information to do any kind of billing. So there's still some loopholes around how that can be shared safely and securely, because it also requires very detailed regulations about who you can share that information with. But then we are contributing our own insights and making sure that whoever wants to be able to make progress along those lines can engage us, and we can offer the benefit of our own experience. But however, we are proponents for shared health records, especially for the purposes of research and care coordination. Regarding how we deliver our medicine safely, so what we have done is, first of all, to make sure that we source and procure our medicines ourselves from manufacturers and authorized distributors of these medicines, to make sure that they are of high quality and safe. The other thing we did is we made sure that we set up a licensed and registered pharmacy that meets all the regulatory requirements within the country to operate a pharmacy delivery service. The third thing we did is to make sure that the staff that we hired had all the necessary qualifications to manage a pharmacy and also do the dispensing. The last mile dispensing is done by a pharmacy technician or assistant. So we made sure that we take the strictest approach to ensure that you have an authorized medical professional actually doing that last handover of the medicines to you, to make sure that we can address any concerns even at the point of exchange, and also to make sure that your medicines are not tampered with in one way or the other from the time they leave the pharmacy and the time that they are received. We also make sure that we follow you up after we have provided you the medication, to make sure we capture any kind of adverse events and document those, and document your outcomes and identify any interventions that may need to follow thereafter if you need to be upgraded to a second line medication in case you're not doing so well. Yeah, the third question was about, if I got it right, investment in data security. Just correct me there if I understood that very well.
Yeah, the legal aspects of personal private information.
Okay, yes, the legal aspects. So, as a healthcare provider, we have to first of all make sure that we adhere to all the existing regulation, even around conventional practice of medicine within the country. So whether it's around storage of healthcare records for 7 years, or making sure that everybody is licensed, whether it's the pharmacy, the lab, the clinic, the professionals, making sure that they have professional indemnity, making sure you're providing the necessary data to the Ministry of Health through health management information systems. You have to make sure that, first of all, you are adhering to all of those. The next layer of that is, because the service that we provide is digital,
you also need to make sure that you have all those internal controls, whether it's your organizational policies around IT, HR, confidentiality, whether it's your technology controls around encryption, access rights and permissions on who can access what information amongst the medical professionals. And then also things like internal audit, where you can track and trace what everybody is doing within the system, making sure that you also follow and adhere to ISO standards around information security and align with those. The other last an important piece is just making sure that you train all the professionals that are involved in the telemedicine service what the value of security is. Fortunately, Uganda has a Data Protection and Privacy Act that it put in place. And I think all practitioners in telemedicine need to look into that deeply and make sure that their practices align with what is law in the country. And that's how we're doing it at the Medical Concierge Group.
Thank you very much, Dr. Davis. Steve, the next question is to you. How do these telehealth systems link with other health information systems, for example, DHIS2?
Thank you, Carol. And I think at the end of the day, it really comes down to standards. And obviously there are a bunch of standards. I mean, there are messaging standards, there are vocabulary standards, but also, I think part of the reason why we've had a lot of challenges with data exchange, of course, I think this has been the complexity of standards and being able to then translate those into usable artifacts, whether those are application programming interfaces or, whatever you call them, whether it's, some integrators or some adapters. But I think over time that's become a lot easier. Many countries, including Uganda, I'm pretty sure, and I'm aware that the Ministry of Health has adopted use of health level 7's fast healthcare integrated resources, FHIR. Most of you have had that. That's becoming like the new technology language for connecting digital health solutions. And that's been adopted pretty much globally now, especially by all the big players, people, the technology space pretty much. And I'm happy that, countries like Kenya, Uganda, CDC is promoting that and big other organizations. So I think for that reason, if we all agree to use certain standards, the ministry, which is really the mandate is in the ministry to champion those standards and provide leadership in those standards. I think Carol will pretty much have it very easy in terms of the telehealth solutions, exchanging data with other digital health solutions like DHIS2 and others that the ministry has already deployed.
Thank you very much, Steve. The next question, which is our second last question, is going to Dr. Vincent. Dr. Vincent, how can we serve those living in hard-to-reach areas using telehealth, but at the same time, protecting them from quack health workers? Dr. Vincent?
Yes, hello again to your question. Just pardon me.
We have people who live in hard-to-reach areas. How can we serve them using telehealth, but again, protecting them from quack health workers and accessing their information in the wrong way, especially during the COVID-19 days?
Thank you so much, Madam Caro. I think most of this has been addressed in the previous communications. Specifically, when we are using telehealth, we need to look at issues of scheduling teleconsultations. And when you are scheduling teleconsultation, that means the platforms for telehealth will need to incorporate licensed health workers who are just licensed to practice telemedicine and who are authorized to use that platform. In this case, the quack health workers will not be integrated or enrolled on this platform. The other thing you can use is maybe the video visits, because in the rural communities, for instance, if you can have these patients record real video visits, which they can upload on the teleconsultation platform. In that case, you'll be able to kind of bridge that gap between the health workers within the urban settings and those who are in rural communities. And in a way, because these platforms are, like in this case, managed like at the national level, let's say in this case, Ministry of Health, whoever is enrolled on that platform will be like the authorized physician or medical worker to require to work with that platform. So in such a way, the quack health workers will not be able to be able to access this kind of mode of delivery of healthcare. Thank you.
Thank you very much, Dr. Vincent. And our last question goes to Kenneth. Kenneth, for our telehealth to flourish, we need some unique patient IDs and some sort of electronic health records. Where are we as a country on this? Thank you. Kenneth, that is for you.
Thank you, Carol. I don't know, the best person to answer this question would have been Paul, I think, but no worries, I'll try to give it a shot. So
I know you will.
So what is happening about unique identification is that you realize that it's not just about having just a unique identifier and stating like the UgHIA health policy says that, okay, use a national ID or use an alien identification number. It's about a couple of things that need to be in place. That to me, because the reason why you need to use unique identifiers is basically to ensure that there's patient mobility. So like, because if you offer, even if somebody had a national ID and in a certain facility, let's say CCA facility like Kirudu, and they presented their national ID and they used their information there and it stopped there. And then again, they went to another place and then they probably presented the same ID or they didn't present one and got services. You know, the wholeness in terms of integrating all this information and having what was termed as a shared record about this person, it's kind of beaten. So the whole essence is that there are things that need to be in place that we've been trying to work on in terms of ensuring that, one, to meaningfully use unique identifiers, one, you need a client registry. You need to agree on some kind of minimum data set that provides a minimum set of information that, when put together into one database or into one registry and some kind of matching and probabilistic kind of triangulation done on them, it will quickly return somebody close to that, to the trueness of that person. So you need to have such infrastructure in place. That is one. You need to agree on the minimum data set at national level in terms, which will involve all other important unique identifiers like national IDs, other alien numbers, driving permits, to name it or a few. But most importantly, you need to connect the facilities. If the facilities are not connected, if all these facilities where these clients seek services from, because today somebody will come to a certain facility because it has specialized services. Tomorrow somebody will go to a clinic because it's an HIV clinic. Another day will go to another service because they have another underlying condition. So every time they are visiting those places, if we are going to meaningfully help these clients and make sure that you understand what is going on in their life and help them appropriately, then there's got to be an agreed mechanism of where some information is shared across regardless of where the person seeks services. And that's when a unique identifier becomes very critical. But most importantly, like I said, you need to put in place, you need to make sure that the various facilities where this person seeks their services are actually interlinked by way of internet. They are really connected so that, in real time, if you have registration as a service or if you have identification as a service, if somebody walks into your clinic, let's say the physics clinic, and just provided a few vital details and, they are checked up immediately and then they're able to identify that and they go ahead and give them a service. So there are initiatives right now going on that have been initiated through the United States government of trying to see how we are supported through certain mechanisms to make sure that we have a client registry in place. So what they've provided is not a client registry, it's basically a model. It's just that COVID really has affected us, but by this time would probably have engaged a wider group of stakeholders to look at it and see how meaningful we build it. And then there are also initiatives going on around to say, okay, how do we build partnerships, either through all the health development partners, some of the existing telecom giants and everything, and ensure that, anything health related, as long as people are using systems that are health related, they are either subsidized or having an internet connection is not priced the same way they are charging other people around, so that we meaningfully use unique identifiers. So pilots have been done, they've been tested, it's a good innovation, it works, but we need to have some things in place first. Thank you. And it's what we are working on. Thank you.
Thank you very much, Kenneth, and our other panelists for answering these questions. We shall post the other questions and their answers on our website. Kindly visit our website, UgHIA.com, to see responses to these questions. Now, allow me, as we conclude, invite Ms. Evelyn Akelo, the Program Manager, METS Program, to give closing remarks for this webinar. Evelyn?
Thank you very much, Carol. And I'm going to keep this really short and snappy so that I don't keep you here too long. I want to add my voice to Carol to say thank you to the panelists. I hope everybody else enjoyed this webinar as much as I did. It's amazing the amount of information that we have out there. And the time just went. I didn't even realize we had spent over 1 hour in this webinar. So I want to really say thank you very, very much to the panelists for giving us a great webinar. For those who are not in Uganda, Uganda is currently under lockdown for 21 days, tentatively until May 4. And we have 63 registered COVID-19 positive cases. But the really great news is that of that, we actually are recording 46 recoveries. So for us as a country, that is really a plus. And I think our Ministry of Health has done us proud, as well as our government. Coming to this webinar, I think COVID-19 has made us think outside the box. And this webinar is just one of such innovations and things that we are doing outside the box. So you can hear us talking about telehealth and how we can actually implement it. And I can say that some aspects of it is actually happening in our country. And this is something that we didn't think would happen. And so I think much as COVID-19 is something that we wouldn't want happening to anybody, I think it has also made us explore our potentials and put in place things that we wouldn't normally have thought of doing. And telehealth is definitely one of them. When I heard the discussions by the panelists and the experiences that were being shared, and the fact that we even know what our challenges are as we explore telehealth, I think we are in the right place really to explore the advantages that it has to offer us. My only hope is that even after COVID-19, it shouldn't be business as usual. The beautiful innovations that we would have put in place because of COVID-19 should continue. I was amazed. I was in a call this morning, and one of the implementing partners was sharing a lesson where they said, actually, previously they used to have missed appointments, but now they had adopted what Davis was actually describing, delivering the medicines to the ART clients. And indeed, they actually found out that the rate of the clients getting their drugs had actually gone up. So they were actually taking the drugs to the patient. So these are some of the beautiful lessons that COVID-19 will teach us, especially how we can make technology work for us. I just wanted to say thank you very much to Carol, the president of Uganda Health Informatics Association. It's a very new association. Carol, when we discussed this in Botswana, I thought it was something we were just discussing, but it's amazing that you've taken it off the ground and you're running with it. Congratulations, Carol. You're doing great. And Jonathan, your vice president, and all those who pitched in. I know, Paul, you must have had a good technical guidance there. And so I want to say thank you to everybody who has been on this call. Thank you to the chair and the person asking the questions. And I do hope that we shall have another webinar pretty soon. We used to say regards, but I know nowadays we say stay safe. So stay safe, everybody. Thank you very much.
Thank you very much, Evelyn, for those lovely closing remarks. I'll not add on to that, but only to thank our participants for your patience and for giving us a very good audience. We definitely will have more of these webinars. Until then, stay safe.